We're going to start now. This is session number 15. And what I thought was we will talk about organ plasma coagulation, especially in the management of cecal angiodysplasia. I would like to thank you all for joining today. And I would like to thank my colleagues, Selvi and Joseph from from MD Anderson, and Sri Ram from UTMB, and my good friend Roy from San Francisco. So I would like to first of all acknowledge the support of my mentor, John Stoline, and Mr. Charles Butt for their support, and Angela Deal, and I'm also grateful to MD Anderson for allowing me to use a Zoom for this presentation. At the outset, I would like to share with you that this presentation is will be recorded and will be posted on the YouTube. I hope you would give me the permission to do so. I would appreciate that. This will help others who could not join today. The way we want to do it is I want to present a case, and as part of the discussion, I put in slides with questions or polling, and then Selvi will put out the poll, and after the poll, the panelists will discuss why do they do whatever they do, and then I will present as the case goes on, along with some of the basics that we need to know to manage patients, especially cecal angiodysplasia with organ plasma coagulation. So this is a an elderly woman with scoliosis, rheumatoid arthritis, on immunotherapy, along with hypertension. She presented with iron deficiency anemia and a 2-gram drop in hemoglobin, and was found to have occult blood in the stool. She undergoes an EGD, which was negative, and she also undergoes a colonoscopy. She is not on any antithrombotics. Of note, she's very thin and she's very frail. At 82, she's almost, she's so thin that you could feel the bones. She's very thin, something to keep in mind. It's important to keep in mind what is happening to your patient before you do any endoscopic therapy. That's why I'm stressing the point that she is very thin and frail. So let me share this endoscopy, and I really appreciate the patient for doing an excellent prep. And this is the endoscopy finding. So we are in the cecum, and as you can see here, there is a lesion. And whenever you see a lesion, it's not just focusing on the lesion, but you also want to see what else is happening in the surrounding. You know, is it on a fold, and whether the fold is of the same size as the rest of the area, or the fold is a little bit thicker. And when you do narrowband imaging, can you see any vessel or draining from that area? So as you can see here, this is something important. I want to share this for the sake of first-year fellows. You can see the fold. It is almost like a C-shaped, and on the top limb is relatively thin. The vertical limb of the C is much thicker, and the down limb, horizontal limb on the downside, is again thinner. So there is something beneath that red lesion that we see. So, you know, for the sake of getting used to how to do a poll, I would like to ask you this question. What is your diagnosis? Let us take the poll survey. So is it a radiation telangiectasia? Is it a blue rubber nevus syndrome? Or is it a Delafoy lesion? Or is it an angiodysplastic lesion? I'm sorry for that typo there. So I encourage all of you to take a poll, and this poll is anonymous. I would not know who answered what, and it's good to have a little bit of feel for what you think, and if you're correct, it's reassuring. If you make a mistake, it's an opportunity for us to learn. All right. So, Selvi, do you
Okay,
want...
Raju, I'll end the poll.
Yeah.
Here are the results.
All right. So let me ask Roy to talk about this lesion. Roy? Okay, let me go back to this lesion and play this, because you can actually take this poll out. Okay. Roy, you want to comment on the lesion? So the key is, in addition to the angioectasia on the NBI, actually you can see a draining vein on the north side of this lesion. And you also notice that there is a little bit of soft tissue mass underneath that. So when you see something like that, you should worry about a larger feeding vessel feeding this angioectasia. As you can see, underneath the angioectasia, it looks a little bit of soft tissue swelling. The reason I want to share that is, whenever you see angioectasia, they are always relatively flat. But when there is a soft tissue mass underneath it, you need to think that there's a bigger vessel feeding. And if you go and do APC straight, you may end up with a bigger vessel bleed, and then you will be firing a lot. And as you fire a lot of APC, you are going to burn deep. And as you burn deep, you're going to create a perforation. Of all the perforations that happen in a colonoscopy, APC-related perforations in the cecum tend to end up with a colostomy. The reason is, when you do APC, everything looks good, you come out, and the patient goes home, patient starts to have pain, and people may ignore the pain, and when they call the nurse, they may say, just take some Tylenol or whatever, but actually that pain is early sign of peritonitis, and by the time they come back, they may have fecal peritonitis that may require a major surgery. So this is something to keep in mind, and not take it lightly. So whenever you see an AVM, is it flat? Completely flat, or is there some mass underneath it? Something to keep in mind. Okay, so let us look at some examples for the sake of our understanding. Here, as you can see, sometimes the angioectasia could be very subtle. You can see a few vessels, and there's a redness here. And in the past, there was a long time back, there was an interesting report that talked about giving naloxone for patients with subtle angioectasias to brighten them up. So if you are taking care of a patient with iron deficiency anemia and nothing else on the colon to explain, nothing else on the EGD, and you think it is angioectasia, but you're not sure how many are there, how big are there. And in that case, you may want to ask your anesthesiologist not to give any narcotics, and sometimes giving naloxone to reverse any of the effects could bring those angioectasia out. So something to keep in mind. So this is one subtle lesion. Another subtle lesion, right? A little bit here, a little bit of changes there. And in this case, it is very obvious that we saw. And then this is another lesion that actually Selvi shared with me. This is angioectasia, and there was active bleeding that you see here, right? So you can have angioectasias in different forms. All right, let's take a poll. You saw the angioectasia. How do you treat this lesion? What do you ask your nurse or technician? Do you want them to set up a multipolar probe or gold probe? Do you want them to set up a cryotherapy or a radiofrequency probe or organ plasma coagulation? All right. You want to share the results, Selvi?
Mm-hmm.
All right. Do you want to comment on that, Selvi?
Sure. So it looks like the majority of people said argon plasma coagulation. I think that's probably what that is what I would do also. I think there may be a role for cryotherapy, but yeah, I mean, I think argon plasma coagulation, I think, is what I would do also.
Okay. So so you have several different options, right? You know, the thing is, most of us will use organ plasma coagulation. If you don't have that, and you have a multipolar probe or any other heat generating device, if you want to use, if you don't have organ plasma coagulation, you can try, but you have to keep in mind controlling the depth of injury. And that is the most important thing in any electrosurgery, especially in the colon. Radiofrequency probe, this has been used mostly for GAVE, gastric antrovascular ectasia, and that is refractory to organ plasma coagulation. You know, recently, last week, we had a patient that kept on bleeding despite APC. Dr. Davula did a radiofrequency application for GAVE in the stomach. When it comes to cryotherapy, you could do that in the stomach, but in the colon, when you do cryo, if it is a gas, it can be a lot of gas coming out. That could be a problem, something to keep in mind. All right. So we all agree that we're going to go with organ plasma coagulation. So how do you set up the APC? And what will you ask your nurse or technician to do? Do you set up with does the patient need a grounding pad or not? And whether you will press on the yellow pedal or on the blue pedal. So I would like to ask Joseph to unmute and then comment on this section. And I want to share with you, Joseph is Dr. Joseph Zhang, one of my colleagues, is actually doing research in this area along with Sanji Suresh. And they've learned a lot by doing an educational research on the same area. So Joseph, you want to comment on this?
Hi, everyone. Sure, absolutely. So, you know, APC is, we have to first recognize what type of polarity we're dealing with, and APC is a monopolar type of device as opposed to a bipolar type of device, and that means that this would necessitate the use of a formally known as the dispersive electrode, or what we colloquially call the grounding pad, so to speak. And so you have to look at your electrosurgery system and determine, for instance, on an Irby machine, there's two windows, the yellow side and the blue side. So you're going to have to recognize where the application resides. And if you look at the blue side, you'll see the effect and the wattage. And so that's a direct indicator that you should be using the blue pedal, because that's where you dictate the type of APC mode that you're supposed to be, or that you want to apply.
So let's talk about, I think this is sometimes a lot of trainees can get confused about what pedal to use, whether to use a grounding pad or not. Do you want to talk about situations where you need a grounding pad or no grounding pad? We have several different instruments that are used for thermal therapy. You have a heater probe. Do you need a grounding pad or not? Or a return electrode? Joseph.
Oh, sorry. So you're talking about MPEC or like a bipolar?
First, a heater probe. What do? Do you need a grounding pad or not?
So if it's a bipolar device, then no, you don't.
So let me help him out. So it's, I think you're talking about a gold probe, Raju?
Yeah. No, heater probe.
So heater probe.
Go
ahead, Joseph.
They're too young to know about heater probes.
Yes, might be
Dr. Graham, why don't you help
the
us here in terms of the heater probe? Do we need a grounding pad or not?
No,
Right. So the heater probe
it's self-contained.
Right. So something to keep in mind, you know, heater probe, you don't need a grounding pad because it is a heating up of the coil, and then the heat at the tip of the probe gets transmitted. In electrosurgery, the electrical current converts into heat, and if it is a monopolar, you need a grounding pad. If not, if it is a bipolar, you don't need it. For a radio frequency application, do you need a grounding pad or not, or return electrode or not?
Yes.
So RFA, isn't it a bipolar device?
So actually, so radio frequency ablation.
Maybe somebody who does radio frequency ablation, because Joseph and I don't. Maybe they want to unmute themselves and comment.
You don't need the grounding pad for the radio frequency ablation.
Right.
Thanks, Joanne, for helping us out.
Right. Radio frequency ablation is again a bipolar device, right? You know, from electrode to electrode and comes back. So something to keep in mind. So you need to keep these things in mind so that when you're talking with your assistant, and if you're using a heater probe for peptic ulcer bleeding, don't ask for a grounding pad because it will, you may look a little bit stupid, to be honest with you. So something to keep in mind.
So the same thing with the gold probe, Raju, that I was talking about.
Right. For gold probe also, you don't need that because it is
right.
a bipolar probe.
Right. So both poles are there, and one delivers the current, and then it also receives the current back and returns it to the electrosurgical unit.
All right. Okay, that's good. So how do you set up? So now that you figured out that you want to set up an APC, and how do you set up your APC? So let's talk about this. You know, there are a few things. It's very simple because we all get confused. And, you know, you press the button to start the machine. And once the machine is started, all the machines have a selected program. You know, they'll set it up for APC or polypectomy or whatever. And here is the angioectasia and the cecum. So you say, I want to select the APC right colon. So you press the button here, and then what happens is, as you can see here, before you press the button, the APC electrode area has not lighted up. Once you press this, this one will light up. So once you press that, the foot pedal icons will light up. And then what you do is, in order to engage that program, you press on that. And then once you press and engage the program, this is what you will see. So it's very simple. Press this button first, power on, select the program, and then engage the program. Basically 3 steps. And then because it is a monopolar device, you need an electrode, neutral electrode or a return electrode, and your APC electrode. And in APC, you deliver 2 things. You deliver electric current and also argon gas. The argon gas is inert, and it can take the electric current in the form of a plasma to the tissue. So that's how it works. And you also want to check whether the gas is flowing by checking whether on your finger. So this is what I've learned from Duke. So, okay. So what APC do you use in this case? We saw the cecal angioectasia. And what type of setting will you use? Are you going to use a forced APC, pulse APC, effect 1, pulse APC, effect 2, or precise APC? So one thing is, you need to understand that in electrosurgery, as long as you know how to use your electrical current to the desired effect, that is the most important thing, because there are so many other variables that will impact. And you could do the same job with any one of these settings. All right. So, shall we want to finalize?
Yes. It's, can you see the results? I already pushed the button.
Okay. All right. So I think we should say is, you have forced APC, people selected forced APC, effect 1, effect 2, or precise APC. As long as you're able to do the job well and direct the thermal injury to just the mucosa and ablate the vessel and don't go into the muscle, that's good enough. You can, as long as you know what you're doing with the device in your setting. So, all right. Let me ask, is Sriram here by any chance?
He is.
Okay, Sriram, you want to comment on this? What do you do?
You're putting me on the mat.
No, it's okay.
That's Sriram, that's the theme for the day, apparently, for all of us. We didn't know we were signing up for this.
Well, this is Raju Army, right? So the point is that I fully agree with you. I am willing to show my ignorance, and I just tailor my usage to the effect that I'm looking for rather than being caught in which form I'm using. So I focus more on the wattage and the amount of time I'm using, and looking for the effect that I'm looking for rather than go by effect 1 or effect 2. But for the sake of selecting, I went with effect 1.
Okay. Actually, that's the most important thing. I want the trainees to learn here that the most important thing is you have to figure out and do what is necessary to have the desired whitening of the capillaries or vessels. You don't want to char it brown. Brown means very deep thermal injury. So The reason I put it out there here is you can actually select any one of those and still get the job done, and still can get the job done safely. So I want to share a few things for the sake of fellows. You know, APC probes, they come in two lengths, and this is mostly for endoscopy. And this one, you can use it for EGD, colon, you know, whatever. And then you also have two calibers, and endoscope has a smaller diameter channel, so it needs only a smaller diameter probe. So something to keep in mind. So one is the length, and then the French size. And then when you talk about the tip, there are different varieties of our APC probes. You know, majority of us use the forward jet or aerial beam. And then if you want to have a side fire, there is a device. And then if you want to have circumferential beam, there is a device. But majority of us use the forward jet. Sometimes when when the assistant doesn't look at what he is opening from the container, then you may give you a side fire, and sometimes this one does not face the mucosa. It may be facing opposite to the mucosa, and then you struggle with that. So it's important to make sure that you ask them for the right device and ask them to check before they open, because these devices are quite costly. Okay. I want to share a few things, right? When you set up APC, we actually saw forced APC, and there are different varieties of APC that we already talked about. One is the forced APC, precise APC, and pulsed APC. And I want to talk about this a little more in detail. Okay. One thing to keep in mind is if you look at electrosurgery units in terms of how much of voltage is delivered, for a soft coagulation, you are delivering less than 200 volts, less than 200. But keep that thing in mind, that soft coagulation does seal the blood vessels. The soft coagulation is also used for preventing polyp recurrence, right, by ablating the edge. But compared to that, if you look at how much of voltage is delivered, is almost like over 4,000 peak voltage. So it's the same for forced APC, pulsed APC, or precise APC. So when it comes to forced APC, I want to share with you, this is something that I've learned after reading multiple times in the last week or so. So if you look at wattage from 0 to 120, and then the voltage, right? Peak voltage 4 or 1. So as you increase the voltage, as you increase the wattage, the voltage increases in this direction. That's the way of the graph. For a consistent effect for forced APC, usually you get much consistent effect at about 30 watts or higher. So something to keep in mind. It is a continuous flow, but the relation between wattage and the voltage is in this fashion. Okay, something to keep in mind. Okay, and how about pulsed APC? Pulsed APC is wattage, peak voltage, and it is constant in terms of the relation between the two, but it is delivered as pulses. And the pulses are, effect 1 is 1 per second. So if you do, so every second, if you put your foot down and keep your probe out, so you have 1 pulse per second. So that is something to keep in mind. But when it comes to pulsed APC, effect 2 It is actually, I don't know why they put effect 2. They should say effect 16, because that's the 16 pulses per second. You know, it would have made more sense to say, you know, for the people to understand that instead of saying effect 1 and 2, they should have said effect 16, so that the people can understand it's a 16 pulses at a little bit of a lower voltage than effect 1. So something to learn about it. And then with the precise APC, the organ beam and the plasma is controlled. And what they have shown is whether you are, sometimes when you're doing a colonoscopy and you're trying to do an APC, the wall could be here. Say, for example, you have your probe here. With the respiration, the wall could be here, or the wall could be here, right? And we try to juggle to maintain the distance. And with precise APC, the way it was set up is as long as you are between 1 to 5 millimeters distance, you have the desired effect there. So one of the things that they talk about it is if you want to keep your probe from a distance and you're not reaching it, say for example, you have a very difficult colonoscopy and you, with a lot of difficulty, you reach the cecum and you are struggling to get closer to the lesion, but the respirations change and you don't know what to do. Not a bad idea to go to precise APC with an effect of 4 or 5. So this is something that I've learned. I've not used precise APC. I routinely use just a forced APC, and I stick to one thing all the time, and it's just my technique. So, all right, let's have this poll. Which part of the GI tract is most sensitive to APC? Is it the esophagus? Is it the stomach? Is it the colon? Or is it the rectum? All right. All right, so you guys got it right. Most of you said it's colon, and let us see what the literature suggests. So if you look at it, from the least sensitive to the most sensitive in terms of the tissue, stomach is pretty resistant, then the rectum, then the esophagus, then the colon, and cecum is the most sensitive. So if you put, like, say, for example, 20 watts to the cecum and 20 watts to the stomach, you'll see a lot more damage in the cecum. So that is something to keep in mind. You also want to keep in mind that the cecum can be very, very thin, especially if you distend it, right? And it's about, you know, if you listen to Jerry Way's talk, he will talk saying that cecum is about the size of 2 dimes put together, and it can become thin if you distend it. Remember that the cecum is papery thin. So, and you recall that I've been worried about my patient who was very thin, very frail, just skin and bones. Imagine if they don't have much muscle mass outside, their visceral mass is also going to be very, very small. So you have to keep thinking about your patient. So the other concept is, before you do APC, you want to decompress so that the wall actually becomes a little bit thicker and you have less issues with gaseous distension as well. All right. Let's take this poll. That is, Selvi, you want to put the poll? So which is the most important factor in determining the tissue effect? Is it the duration of activation? That is, how long do you put your foot on the blue pedal? Is it the power setting? That means how many watts are you putting? 20 watts, 30 watts, 40 watts? Or is it the distance between the probe and the mucosa? Whether it is 1 millimeter, 2 millimeters, and whether it is the type of the probe. Is a forward, circular, or side firing. All right. I'm glad that you all got right quite a bit. I think, so let us look at what the literature says. So before I go there, I think the art of electrosurgery or art of APC is to limit the depth of thermal injury to the target tissue and you don't want to go beyond that. If there's a mucosa, just ablate the mucosa. You want to control that. So when you look at determinants of the thermal injury, so you got your APC catheter, and you are applying energy for a particular amount of time, keeping the distance at a particular distance to an organ in the GI tract. And it could be esophagus to colon or rectum, and you know that the cecum is very thin. So all of these factors, how long do you apply the current, the amount of wattage that you set, and where do you set your probe, and which part of the gut are you treating, make a difference. And let us talk about which of these play a role. All of them play a role, but what they've shown is how long do you activate. Say, for example, you're activating at this point without moving your probe. That duration of activation is going to cause a lot of deep thermal damage. And then if you increase the power setting, again, more damage. If you keep the probe very close, again, more damage. In terms of the relative importance, this actually is the most important thing. So the reason I want to highlight or stress this one is for the fellows to keep in mind how long do you tap on that blue pedal. And you need to learn how to gently tap so that you do not increase the duration of activation, so that you just give small amounts of APC. All right, so let's look at the data. So here is colon, and they kept it at a stable distance, and they've used 45 watts. And in this one, they delivered it at 1 point for 1 second. That is about this amount of the energy total delivered. And again, the same thing, same wattage, but longer duration, and and the same height. As you can see here, when you do that, you may think that you did a good job. You may see whitening or may see a little bit of browning, but you don't know what is happening below the APC effect. A lot of fellows think that you cannot perforate with APC because the tissue desiccates and the gas goes to the next area. That is not true. So let us see what happened to this experiment and this experiment. So when you look at histopathology, with 1 second, the damage is just limited to the mucosa and maybe a little bit of submucosa. But when you give it for 3 seconds, it actually goes all the way to the muscle. Once you destroy the submucosa, the strongest layer in the gut is the submucosa. If you keep the submucosa intact, your healing is going to be great with less risk for perforation. Once you damage the submucosa and start damaging the muscle, there is a high chance that the patient may end up with a perforation or post polypectomy or post coagulation syndrome. That means the patient comes back with pain and maybe they can have fever, but if you do CT, they may just have a little bit of fluid, but no perforation. So it's very important to not keep the probe at one point and keep buzzing at one point where you char that area. That means that area below is going to develop a perforation. So the same concept, again 3 seconds, but here we applied 3 seconds of energy after creating a submucosal saline bleb or some solution to lift the mucosa away. When you do this, what happens is you protect the deeper layer from damage. So this is a concept that you want to keep in mind. And this concept actually was shown by the group at Mayo a long time back, almost 20 years back. And when you have a patient with the angioectasia in the cecum, although it is very easy to apply APC and get out, take some time and create a submucosal bleb and protect your muscle and your submucosa from deep thermal injury. So we talked about all the concepts. So learn how to apply the minimum amount of APC to get the desired effect. Okay. So let's talk about it. How do we do this, right? How do we keep your activation very short? I think this basically boils down to practice the gentle tap tap on the blue pedal so that you have very little energy going in. It's very easy to put your foot on the pedal and see nice brown charring. That means you are damaging the deeper layers. So keep the activation short. Learn how to tap tap on the blue pedal. The second one is start with a low voltage, especially if you're not sure for angioectasias to see where you get the just a whitening. And then if you want, you can increase. With experience, you will figure out. But if you're starting, always start with a low voltage. You can always increase. Third thing is you want to keep the distance away. But if you think about the thickness of the probe, if it is a 10 French probe, it's about 3 millimeters. The one wall will be about 1 to 1.5 millimeters in thickness. So as long as you have the probe like this, even if you touch, it's not going to have much damage. But on the other hand, if you have the probe like this and fast, you're going to have a deeper injury. Something to keep in mind. But if you're not able to maintain the distance, I would suggest that don't go with forced APC. Maybe you want to try precise mode. And the precise mode works precisely only up to 5 millimeters. Beyond that, it doesn't have the same control. So let's get back to the case, and I'll show you what we did. So we decided to inject, and based on some of the literature, I use saline with a little bit of AP. The dilution is about 1 in 100,000. And one thing I had to I want to share with you is this was not an easy colonoscopy. I had to struggle because of our scoliosis. And there is the colon was not easy to reach to the cecum. And I thought that, okay, I need to take every precaution in her case. So your assistant should tap. But here, when you tap, it didn't go into the submucosa. It went into the mucosa and created a bleb. When it happens, they do stop, and then you puncture a little bit deeper to get into the deeper submucosa. So once we have this, then I used forced APC. That's what I trained with. My mentors trained me on, and I've not changed. But I've used 15 watts, and as you can see, I'm gently tapping. I'm not tapping it to create a long application of the current, and I'm just going one tap to coagulate the vessel. I was actually, I have to admit this, I was very concerned to do this, concerned about her because she was so thin. And I thought that if I don't take all the precautions, I may end up with a delayed perforation. So that's why we injected, we used a very light current, and we wanted to go slow. So after every application, I'm seeing what's the effect. And so after this, I went ahead and actually clipped that area. You may wonder, why the heck did you clip? As mentioned earlier, I wanted to limit any delayed effects, although my treatment was very, very superficial. I was concerned about her. She was in her 80s. And as you can see, once we applied a clip, there was a little bit of blood from the deep, indicating that there was a vein. If you actually go back to the first video and look closely with the MBI, you could see a big feeding vein underneath that submucosal bulge. It's interesting that I did not see that at the time of the procedure. All I saw was a little bit of bulge that made me do all of this, assuming that there's a big feeding vessel. But when I was trying to prepare for this talk and I was going through this video, I recognized that big feeding vein. And so if you want to check it out, actually this video is on the YouTube. You can go back and check that vein, you could see that. The other thing you have to keep in mind is when you are doing a colonoscopy and you go through multiple loops and you reduce multiple loops, when you are coming back, you have to think that those loops are going to form and it's going to be a closed loop. And any amount of distension that you create can cause unnecessary problems to the patient. So let's talk about the last one. Which of the following is responsible for colon explosion? Is it the APC power setting? Is it the amount of time you put your foot on the pedal, application time? Is it the APC of the cecum or APC in a dirty colon? All right, that's good. I'm glad that people got that thing right. Actually, it's sad to see this. I just saw a case report just recently in one of the journals where somebody went ahead and did an APC of radiation telangiectasia in the rectum without proper full colonoscopy prep. They gave a couple of enemas and they went ahead and did the APC. And that is actually no, to be honest with you. And I don't know why they have done that in 2020, 18 or 19 because they just reported it this year. The patient had a colon explosion, and they actually reported that the patient actually survived. Because patients with colon explosion, this happens because of the gas, the methane gas in the colon. And when you do electrosurgery in the colon that is not prepared with a full colon prep, the methane gas can explode. So you should not do this. You should not do any electrosurgery in a patient whose colon prep is not good. And
Will CO2 protect you?
see, we don't know that. People talk about it and say that can we evacuate the whole colon and use CO2 and exchange CO2 for that? People talk about that as a measure, but I say to myself, if there is a radiation proctitis or radiation telangiectasia and you want to do APC, probably safer to just go through the whole prep rather than giving them an enema and then trying to do CO2, because you can't go all the way up to empty the whole colon. So I don't know.
Enema doesn't prevent the CO2, I mean the methane from forming.
Right.
So we always use CO2, everyone.
Right. So you do prep them like a colon prep, or you do with just a fleece enema?
We'll do it with just a fleece enema and CO2. But you know, explosion's unlikely, but we've never had one and hope never to have one. But if we had one, we would never report it.
Okay. I think, yeah, but it's a scary thing. You know, people say that, all of the things I've read is people say that there's a pop sound in the endoscopy unit and the scope came out, and most of the colon explosions happened when people were preparing their colons with mannitol. Most of the fellows may not have used mannitol because in the past, before golightly or PEG-based solution became available, thanks to the work of Dr. John Fortran from Dallas, people use mannitol, and that's one of the concerns. So thank you for your comment, Dr. Graham. Thank you, sir. So in terms of the precautions, I just want to summarize to help us, okay? One is pain, especially most of the pain and discomfort from use of APC is the use of a lot of gas. So you want to periodically decompress the colon as you're doing the procedure, especially if it's a long procedure. And organ gas doesn't get reabsorbed like CO2, so you have to suction it out. The second one is pain can happen if you're doing a low rectal polyp and you apply APC close to the dentate line. That could be the reason for pain, but they get better with time. You can ask them to have some lidocaine gel or whatever locally applied. The other thing is you can see mucosal blebs of organ gas if your probe is very close to the mucosa. That can happen, and usually that doesn't lead to much, but if you do an X-ray or something after that, you can see a gas under the dome of the diaphragm, and you may be worrying whether you caused perforation. So something to keep in mind. And we talked about colon explosion, and then perforation. You avoid perforation by using a short duration of application and low energy to start with, and then get into the habit of creating a saline bleb. So I would like to open it up for discussion, and I would like to invite the panel for comments, and also Dr. Graham and Sylvia.
Hi, Dr. Raju. Wonderful, wonderful talk. I want to revisit the poll question with regards to the APC mode that you had everyone kind of select which mode would they use. And my comment there is that while it's true that you can probably achieve whatever effect with either mode, whether forced, pulsed, or precise, My personal, if in this scenario specifically, my personal preference may be to choose pulsed effect 1, only because if I want to be cautious and not run in and not have to worry so much about, how long is my foot on the pedal. If I have my setting on pulsed effect 1, then I'm guaranteed to only be able to deliver 1 application per second, so that if I at least let go of my pedal before that next cycle, then I can guarantee that I only get that 1 flash. That way I don't run into the problem with continuing trying to ablate that lesion and risk some kind of injury. So my preference in that case would be to select pulsed effect 1. Because even if you select 2, like you mentioned, you get 16 pulses in that same second, and that's hard to control.
That sounds good. The key is, for the sake of fellows, you with electrosurgery, you learn a particular technique and then stick with it as long as you're doing well. So that's the most important thing. But at the same time, you want to learn different options, especially different modes that are available, so that if you are in a difficult situation and you're not able to maintain the probe at a particular distance, and then using a precise mode may not be a bad option, And I have to say this, I have to admit this, I did not use precise mode so far, but reading the literature, it looks like it's a good option to have it in your back pocket.
I agree. Yeah, especially if the colon's very mobile, if it's very spastic and you're not able to control that distance, then yeah, then the precise mode I think is kind of a safety guard in that scenario. Another thing I want to bring up is kind of how far the APC probe should be out in front of the endoscope. You showed us the schematic of sort of the actual probe, and it has little black markings on it, and I think the manufacturer recommendations is that you're supposed to have that first thick black marking at least partially visible, so that you don't cause any damage to the endoscope.
Right, you're right. So you're right that the manufacturer recommendations are, you have 1 centimeter markings at the end of on the probe, and they say that okay, these markings could be used to measure the distance of to measure the particular lesion or a resection. But most importantly, they say that you need to see 1 marking outside, so that you don't burn the tip of your scope. So if you use a cap and your cap is about 2 millimeters outside the scope, and you are for APC of angioectasia is different from ablating a lesion or cutting a stent. In those conditions, you would use a lot more wattage because you want to destroy the tissue or destroy the metal of the stent. In those cases, it makes sense to have your probe as far out as possible, at least 1 centimeter out. But the key is, whatever you are treating, it should be visible to you. You cannot do like a blind chip shot. That's not a good practice.
Raju?
Yeah, Shelby, go ahead.
No, go ahead.
No, go ahead.
No, I just was wondering if you and others could maybe comment on what the optimal effect is on the mucosa. What is, when you do APC, what are you looking for? What is too much?
Okay. So I am actually a conservative guy, you know that, right? So I try to, and then reading the literature, and I was just reading a review article written by Michael Book just recently to just see what his thoughts are. And what I do is, For angioectasias, I try to get whitening, not a deep brown or a dark brown effect. That's the goal, especially in the cecum. I'm very, very uncomfortable doing a deeper thermal injury. So my goal for angioectasias is whitening of the vessels and obliteration of the vessels. When it comes to APC, after resection of a large flat lesion, I've actually, for the last 10 years, I've been using APCs routinely for all large polyp resections. And my settings were 35 watts, 0.8 liters, forced APC. And I try to get a deep brown effect of the mucosal edge all around. And I take pictures before I do APC, and I take pictures after I do APC with a cap-fitted endoscope, and I want to get a deep brown effect. You may ask, okay, if you get a deep brown effect, aren't you getting a deep thermal injury? That's true, but all of these cases are done after submucosal injection. There is enough lift of this mucosa. So I've not had any delayed perforations, except one in the last 12 years. And I don't know, I can't come up with an explanation for that perforation. I don't think it was APC related. But deep brown effect, our recurrence rate is very low, compared to what was published in the literature, about 3 to 4%. And if you look at the latest paper from a randomized trial looking at looking at coagulation mode versus endocut mode, they reported that they had about 17% recurrence rate, which is quite high, and I don't have an explanation. But if you actually do examine the edge with a cap-fitted scope, make sure there's nothing visible, and apply APC to get a brown effect. With that, those two settings, the recurrence rate, at least here we reported, was about 3 to 4%.
Dr. Raju, may I have a question?
Yes, ma'am.
Thank you so much for sharing this very instructive case. My question is regarding the risk of colon explosion in a dirty colon. Fortunately, I have never seen such a complication, but I was wondering, how do you define a dirty colon in such a situation? Can you be a bit more specific? Because assuming the patient is an old and frail patient with comorbid conditions, there is a high chance the bowel is not optimally prepared. So we reach the cecum, we identify the lesion, and we say, well, she's not well prepared for APC. Could you define what is good bowel preparation in this case? Should we use the BBPS scale, or what is your experience?
Sylvia, I'm glad that you asked me that question. And I think when you're doing it in the cecum, you would really want to get at least a bowel prep scale of 7 or 8. That's what is necessary. But we do have patients, when they're frail, they can't really do the prep right. And I have to explain this. I had one patient where the prep was not satisfactory, and I could see bleeding angioectasia, and the prep was not satisfactory. And I was on the back of the mind, I was thinking about whether I will be in front of the morbidity and mortality conference as I was opening up my APC probe. So this is what I've done in that case. What I've done is that I basically cleaned that segment as much as I could, but there was still stool. And I basically sat there and suctioned all the gas because we use CO2, and I hope that the CO2 would have eliminated any methane gas. And in addition to that, the other thing that I did was I filled the entire cecum underwater, and the cecum and the ascending colon underwater. And then I did, you know that we can do the APC underwater, right? So I actually did APC underwater. Hoping that my whatever I'm doing is not going to get, there's no methane gas underwater. I don't know whether methane gas gets dissolved in the water, but that's what I've done. If it is all stool and it is in the right side of the colon, then if you are too much worried, I would actually maybe what I've done also is put a lot of water into the colon and let them have like a colon lavage, come out, and then bring them back later in the day with a little more golightly or whatever, and then do the procedure again.
Thanks a lot. Very, very
we
helpful.
have actually, go ahead. Go ahead.
No, thank you. That it's very helpful.
Right.
There are a lot of good lessons to learn.
Right.
Thanks a lot.
Yeah. Let's ask Dr. Graham. Dr. Graham is here. Dr. Stolan is here, and they have a lot of experience. What they would do when they have a dirty colon and they have to do an APC on the right side of the colon. Rectum is, we understand that they've been doing it with just enema and CO2.
I don't see Dr. Graham on the call anymore.
Okay.
He may have had to leave. Maybe Roy Dr. Satikno can give us some comments.
I was thinking about the last question that Sophia was talking about. I think if there's a concern of explosion or anything like that, then you would just clip, no?
Yes, you could do that. Actually, it's an interesting concept. Actually, if you look into the literature, there are people who have actually talked about clipping. And when I was in Galveston, I had one patient who had a bleeding angioectasia with a fresh coronary stent, and he could not come out of the antithrombotics. And if you trace fortunately in that one, you could trace the feeding vessel very nicely. And I said to myself, okay, like a surgeon, you apply clips along the vessel and try to create stasis so that the vessel gets thrombosed. So that's what we did in that case. And I believe that was published in GIE as a case report or something like that. So that's another concept we can try and do that,
I think in regards to the clipping, the two ways that you could do is one is like what Raju says, which is to say, okay, I'm going to clip from the feeding vessels from the center so that you don't have much bleeding during the clipping process. Or you actually clip using the zipper method where you clip from one end to the other end serially and parallelly. I think the beauty of doing it from one end to the other end is that you actually will cause the feeding vessel to burst. And by having it burst, you continue to clip it, you will see that your clipping is actually effective because at the end of the clipping, you should not have any more bleeding. So it's like a test that you have done the clipping completely.
So thank you, Roy. Thank you so much for that input. This is a question from Joanne. She asked this question, can you discuss MD Anderson preference of cautery pad placement? So I will talk about when you're doing colonoscopy. We place the pad on the right flank. That's where we place the pad because you want to keep the pad to the electrosurgery field the distance as short as possible. That's where we place in the right flank, not on the thigh, not on the buttock, but on the right flank. If you're doing a ERCP, I think the best place to place it is on the back, so that at least it's not in the field of your in the field of the ERCP, but in the back.
Raju, can I ask a question?
Yeah.
How did the patient do after the APC of the cecal AVM? Did her hemoglobin recover? Did she have? She did fine.
No, we just did it just last week. You know.
Oh, I see.
Last week. So that was, let me. Sriram, any comments?
No, I think it was a beautiful discussion. Yeah, I had two other situations, and the way I look at it is that in case of suboptimal, I used to do APC even in suboptimal preps, but because the incidence of explosions is rare, but we don't want that rarity to happen to us. So with time and graying of hair, I tend to become more conservative and not doing it anymore and cleaning. I'm focusing on cleaning. And then I start asking a question, why am I doing this? And what is the urgency for doing it? And suppose the urgency is because the patient is on anticoagulation and active bleeding, then my immediate goal is to focus on dealing with the immediate issue of bleeding. So I inject epi and put a clip and come at a later date to burn the tissue if necessary. And so that's what I've been practicing. And I had a similar situation on a patient with a duodenal flat adenoma with an angioma on top of it, which she bled while on anticoagulation and antithrombotics. So I initially injected and clipped, even though it's a duodenal adenoma, and later on, once the cardiac issues are sorted out, came back to deal with it. So that's how I look at it. The additional thing is that, of course, the underwater APC, and the third issue is in terms of cleaning. If the bowel is not very kinky and colonoscopy is not too difficult, then there are other ways to clean the bowel, like pure lavage, basically high volume lavage with either other devices or just the colonoscopy itself.
Right. Thank you so much. Thank you.
And one more comment is about the clipping. If depending on the size of the lesion, I try to go tangentially to include the tissue into that AVM so that I can capture the underlying submucosal vessel as well as the mucosal lesion into one quick clip so that everything comes in one go.
Right. That's good. Thank you.
Dr. Raji, I want to give some spotlight for sort of since we're on the topic of angioectasia, sort of a variation of this that can occur in LVAD patients, or patients with left ventricular assist devices. And they have sort of a unique pathology. They sort of resemble angioectasias. Where I trained, we used to call them pseudo-dulifoid lesions. But these are patients with LVADs who, so because of this low pulse pressure and this continuous flow, there's angiogenesis that can occur in the small bowel in particular, and these patients can often come in with recurrent bleeding and they're on anticoagulation. And these patients we also treat with APC. We actually would inject around the area first to sort of get some field effect with epinephrine and also to isolate the actual lesion, because these, unlike traditional angioectasias and these lesions, they're not necessarily a distinct visible entity. They sort of ooze from the mucosa, and so the epinephrine sort of kind of decreases the bleeding, isolates that area pinpoint bleeding, and then we also treat them with APC. So that's a kind of a unique variation that some people who may be at facilities where they have LVAD patients may have to deal with.
All right.
Yeah, that's an excellent comment. That's an excellent point. We have a few LVAD patients who keep coming. And one of the other things that in addition to EP and APC, what I do is always end it up with a clip because they need to be continuing on anticoagulation. And whatever mucosal injury that I have caused because of the APC treatment will eventually form an ulcer before it heals with fibrosis. And during that window period, to increase the additional chances of bleeding, I always end up with a clip.
Oh, that's actually a good strategy. Yeah.
I think one final comment that I want to make is, for the sake of fellows, when you see an angioectasia and you think it's the cause for the bleeding, before you do anything, check, is it relatively flat or does it have some tissue underneath it? If it has some tissue underneath it, that means it has a bigger feeding vessel. So in those cases, don't just jump and put your cautery probe on that. It's going to bleed, and then you're going to burn more, and you're going to burn more, and you'll end up with a deep thermal injury. So think about the lesion and the surrounding area, and take the precautions. You know, if you think that there's a big submucosal vessel, inject epi, cauterize, clip. So use a combination method that would help the patient. All right. With that, if there are no other questions, we will we'll end the session. And I want to thank my panelists, Selvi, Joseph, Sriram, Roy, and thanks Sylvia, and all my colleagues from MD Anderson and others from other parts of the world. Thank you. And hope this is helpful to you. Thank you.
Thank you, Raju. Thanks, everyone.
Thank you.
Yeah.